My name is Chaplain Wei, and today I'm going to talk about nephrotic versus nephritic syndrome. Nephrotic syndrome primary pathology is that glomerular damage leads to increased permeability to proteins and presents with massive proteinuria measured at greater than 3.5 grams per day. Hematuria is absent or rare. There is severe edema, generalized, due to hypoalbuminemia. Blood pressure is typically normal or slightly elevated. Serum albumin is low due to urinary loss, and there is marked hyperlipidemia from compensation liver synthesis of lipoproteins. And urinary casts present as fatty casts. But in nephritic syndrome, the pathology is glomerular inflammation leads to damage to the glomerular capillaries, impairing filtration. There is mild to moderate proteinuria, it's less than 3.5 grams per day. There is gross or microscopic hematuria, often with dysmorphic red blood cells and red blood cell casts. There is mild to moderate edema, but less than presented in nephrotic syndrome. Blood pressure is often elevated due to fluid retention and activation of the renin-angiotensin-aldosterone system. Serum albumin is normal or mildly reduced, and urinary casts consist of red blood casts and granular casts. In nephrotic syndrome, complement levels are usually normal. The key symptoms are frothy urine, which leads to severe swelling. Primary causes consist of minimal change disease, focus segmental glomerulosclerosis, membranous nephropathy, and other secondary causes such as diabetes and amyloidosis. Management consists of diuretics for edema and ACE inhibitors to reduce proteinuria. There's also corticosteroids or immunosuppressants that can be used for some causes. But in nephritic syndrome, complement levels are often low. For example, in post-streptococcal glomerulonephritis and lupus. There's also hematuria in the key symptoms, often described as cola or tea-colored, and also oliguria. Primary causes of nephritic syndrome are IgA nephropathy, glomerular basement membrane disease, also known as Goodpasture syndrome, post-infectious glomerulonephritis, and secondary causes such as systemic lupus erythematosus. Management consists of blood pressure control with ACE inhibitors and ARBs, and also treating the underlying cause, such as strep with antibiotics, immunosuppressants, or plasmapheresis as needed. In pediatrics, some common diseases of nephrotic syndrome are minimal change disease, which is the most common, consists of 80 to 90% of cases. It peaks at 2 to 6 years old. And then there's also focal segmental glomerulosclerosis, and that's more common in older children, and is typically either idiopathic or secondary due to obesity, genetic mutations, and other secondary causes. Common examples of nephritic syndrome in pediatrics are post-streptococcal glomerulonephritis. It's typical in children 5 to 12 years old and is typically have a history of streptococcal infection 1 to 3 weeks prior, especially as upper respiratory infection. Serum complement consists of low C3, normal C4, and other lab findings are elevated ASO and anti-DNase B. Another common disease is IgA nephropathy, also known as Buerger's disease, and it typically presents as recurrent episodes of gross hematuria with a history of upper respiratory infection, and the common levels of C3 are normal. Other common diseases are Henoch-Schönlein purpura, is also known as IgA-mediated vasculitis, presents as a purpuric rash, abdominal pain, arthralgia, hematuria, and proteinuria. And lastly, there is systemic lupus erythematosus. It also presents with nephritic symptoms such as hematuria and proteinuria, and there are also systemic symptoms such as fever, rash, which is most common in face and extremities, and also joints pain.